speech-language pathologist can also help with that. If you guys have any questions about this, you can ask me after, or my email's at the end, since that's not the focus today. Okay, so swallowing and Parkinson's disease. So the medical term for swallowing disorders is dysphagia, and it's estimated that 80% of people will develop some form of dysphagia throughout the progression of their disease. However, only 3 to 4% of people actually get recommended to see a speech-language pathologist for evaluation and treatment, meaning it is vastly underdiagnosed and underreported. If you're not sure what the symptoms can look like, here's a list of symptoms. So if you feel like something's getting stuck in your throat when you're eating or drinking, if you're coughing or choking during your meals, you have a change in voice quality during or after your meals, you feel fatigued, you still have food left in your mouth after you're done swallowing, those are all signs and symptoms of dysphagia. Dysphagia can also result in something called aspiration, which can result into aspiration pneumonia. So if you're wondering what is aspiration, aspiration is the medical term for when something goes down the wrong pipe. So if you're wondering how that happens, I'm gonna come over here real quick. So right here, this big opening is our airway. And then behind that, that tiny little opening is the esophagus. So it's small and it's closed off because we're not always swallowing. Our airway is nice, big, and open because we're always having to breathe and talk, right? So that airway remains open when we're talking, when we're breathing. This little flap over here is an epiglottis. It closes off our airway whenever we swallow. And then our airway is supposed to kind of move up and out of the way with use of some muscles to allow everything to pass. There's a sphincter at the top of our esophagus that opens up to allow our food to pass. So lots of movement involved. It takes over 30 muscles, 5 cranial nerves to swallow, and there's about 17 components. So it makes sense that Parkinson's, a movement disorder, might impact the swallowing process because it is one of the most finely coordinated movements that we make. So normally, whenever we have an aspiration event, we want to have a cough response. Okay, so that's our body's way of protecting itself. Sometimes aspiration can be silent, meaning your body does not cough or respond. So the best way to know if that's happening is to get a swallow study, which we'll talk about in a couple of slides. Over time, this aspiration event can result in that pulmonary compromise or aspiration pneumonia. So again, a strong cough is an important part of airway protection. Not just a little cough, like a strong cough, like you're trying to get something out of your airway, because you are. So possible symptoms of aspiration pneumonia are frequent coughing with mucus, chest pain when you're coughing, shortness of breath, fever, temperature spikes, or extreme fatigue. A chest x-ray is required for diagnosis. So how can I reduce my risk? So physical mobility and exercise is not important just to reduce weakness and rigidity and stiffness. Having a strong physical body as much as you can is gonna help you fight off infection, okay? So you're gonna get better blood flow to your lungs, you're gonna have better musculature, just better equipped body to fight off infection. Some other things are thorough oral care and regular dental visits. So our mouth contains billions of bacteria. So if something that you're swallowing is going down the wrong pipe and that bacteria goes down with it, you're more likely to get an infection. So thorough oral care looks like brushing 2 times a day, every day for 2 minutes. If you don't have teeth, you still have gums, you have a tongue, brush those gums, brush that tongue, get your mouth clean, see your dentist as well, and that's a huge part of infection control and prevention if you are aspirating, because we can't always control aspiration, but we can control how much we're moving and how clean our mouth is. Other precautions, so avoid multitasking during mealtime, concentrate on chewing and swallowing. Like anything else with Parkinson's, we have to be purposeful and intentional, okay? So you have to focus on what you are wanting to do. If you want to swallow safely, focus on swallow safety, enjoy the meal. That is a time to eat, not a time to do something else, so enjoy that meal. Sit upright at a 90-degree angle during and immediately after your meals. That'll allow all your food to pass down as needed and not reflux up. Reflux can also sometimes end up going down the wrong pipe. If you feel the urge to cough, we just talked about this one. That is your body's way of protecting itself, so use it. Don't talk with food in your mouth. As you saw, the proximity between our airway and esophagus, they're right next to each other. So whenever you're talking while you're eating, you're putting yourself at more risk of something going down the wrong pipe. Take smaller bites of food and swallow completely before taking another bite. You just have better control when you're doing that. And see a speech-language pathologist for individualized recommendations. Okay, so if you're wondering, how does this get diagnosed or evaluated? So there's two types of swallow evaluations that we use. One is called a modified barium swallow study. So this is basically an x-ray of your swallow muscles, and we're gonna get to see how it looks like here in a minute. But basically it's an x-ray of your mouth, your throat, the top of your esophagus going all the way down, and from there we can see what's going wrong so we can determine an intervention plan, so strategies or exercises to help rehabilitate your swallow. The next one is a fiber optic endoscopic evaluation of swallowing, or FEES, that's a mouthful. So this one is done transnasally, so it's a little tube that passes through your nose. There's a camera on the end, and that camera allows us to look into your throat and see what's going on and if things are going down the wrong pipe and why. So we're gonna get to see what these both look like. Okay, so this first normal swallow side is what's gonna play first, so you're gonna get to see what a normal swallow looks like, and then the abnormal swallow will play after. Brief anatomy thing, so this kind of opening right here is the windpipe or the trachea. That kind of closed off space is the esophagus, that's the mouth. Epiglottis is kind of like up there, you can't see it too well, but the food you'll see, it's like a dark contrast, and so you'll get to see how that goes down. So pay attention to the normal swallow side first. So we're gonna see the food going down the esophagus, not the trachea as it should. Super cool, right? Just nice, neat, beautiful swallow. Then this one's not gonna look so good. So we have some food kind of sticking, and then you see it's going down that front pipe. That's what we don't wanna see. And then there's some residue. So that is a modified barium swallow study. So that is, I would say, probably my favorite way to get the swallow assessed, because from there we can see what muscles we need to target so that you're swallowing better. And that's the only way we can really determine if that silent aspiration is happening, because I can't see inside of your throat normally, right? So this kind of gives me that X-ray vision superpower so I can actually see what's going on. Next, we're gonna look at a FEES. So this side is gonna play first, so this one's gonna be pretty quick. It's gonna go down nice. This one, I'm sorry if anyone's grossed out and everyone loves this, but I think it's cool. So this bottom part is gonna be the epiglottis. It's that flap that covers our airway. Our airway is that gap right here, right in between our vocal folds, which are these two tissues, and then behind that and kind of around it is the esophagus. So that's gonna be an impaired swallow. You're gonna see some liquid go down the airway. And then you'll see what coughing looks like. So this person's trying to cough out the residue, and they do. So this side will play first. So this is gonna be a nice, clean, quick one. Beautiful, no problem. And then this next one's a little messier. So the vocal folds aren't closing all the way. That sometimes happens in people with Parkinson's, which is why we experience those voice changes, but that person is coughing because something went down the wrong pipe. And now it looks pretty clear in there. Their vocal folds, again, aren't closing all the way. Our full vocal fold closure is another way to help protect our airway. So if you have started experiencing voice changes, it might mean that your vocal folds aren't closing all the way, so that is a risk factor. And we'll talk about that here in a minute. But anyway, those are the two main types of swallow studies that are performed now. There's research ongoing for some other ones, but it's not quite there yet. And something I forgot to mention, so cough. Cough is particularly important for those with Parkinson's. Again, sometimes we can't control aspiration, but a cough is going to help protect that airway. So there's ongoing research right now on treating reflexive cough in those with Parkinson's using an aerosolized capsaicin. This is still just research-based, so it's not available clinically yet, but we are hoping to have that be part of dysphagia intervention. Which now we're going to talk about intervention options. So what do we do if we have a swallowing problem? So there's some different options. Diet texture modifications. So sometimes adding a thickener to your liquids can help. So thicker liquids have more viscosity, allowing them to go down slower. So if your swallow is delayed, using a thicker substance can help your muscles coordinate to allow everything to go down the way it needs to. Avoiding tough to chew or dry foods. So cohesive foods are easier to chew and to swallow, and then to swallow, they don't break apart. There's not little crumbs that get stuck. So cohesive foods are typically easier. Compensatory strategies, and we'll actually get to try these. So one strategy that might be recommended is called a chin tuck. So I'm going to talk you guys through this. If you have water, take a sip. If not, just use your saliva. But basically what everyone is going to do is you're going to look down as if you have a newspaper in your lap, okay? And then you are going to, if you already took a sip of liquid, you're going to swallow. And then you're going to look up. And that is called a chin tuck. So what the chin tuck does for some, it does need to be visualized under one of those swallow studies, but it can move your airway up and out of the way, open up your esophagus, and allow the liquid or food to pass down a little bit slower. So that is one that could be helpful for some. For some, it can actually worsen your risk, so you have to get a swallow study to see if it's right for you. Don't just blindly do it. For some people, it does help reduce those coughing episodes, though, so it's something that you could try out. The next one is called a breath hold. So as you saw, for some people, the airway doesn't fully close. When we hold our breath, our airway does close off. So for this one, again, if you have a sip of liquid, you're going to take that. If not, just use your saliva, but you're going to hold your breath. You're going to take a sip while holding your breath, and then swallow. All the while holding your breath, and then you release. So that is another one that we would want to see under swallow study to make sure that it is a right approach for you. So there's other compensatory strategies as well, but those are the two that I see most commonly for Parkinson's. Adaptive equipment, we'll talk about that in another slide. Exercises, so we'll get to try the first two. So one that I like is called a hard swallow or effortful swallow. So the way I like to explain this one is pretend you're swallowing a peanut butter and jelly sandwich with white bread. The amount of force and power it takes to swallow that compared to, let's say, like a pudding or a yogurt, you're going to use a lot more force to swallow that peanut butter and jelly sandwich with white bread, okay? So what I want everyone to do, again, if you have anything to drink, take a sip of liquid. If not, use your saliva, and then I want you to swallow as hard as you possibly can, okay? Again, you're swallowing that peanut butter and jelly sandwich, okay? You should feel the back of your tongue touching the back of your throat, these muscles really working. So therapeutically, I would recommend doing several sets and repetitions of this. That's what makes it an effortful exercise. Every person is different, so it is recommended to see a speech-language pathologist. I also use electrodes typically as well for that to increase the intensity. If you have any questions about that, feel free to ask me after. The next one that I really like for Parkinson's is called a tongue press. So for this one, I'm going to talk you guys through it as well. So you're going to use the tip of your tongue, and behind your top teeth or gums, there's your hard palate, and there's like a little groove, okay? So with a slightly parted mouth, you are going to use that tip of your tongue, and you're going to find that groove, and you're going to press. Okay, and you're gonna hold. And in order to see if you're doing it right, you can use these two fingers, kind of feel right here. You should feel a little bulge. And that's your submental muscles working, and those are some muscles that help elevate your larynx. And then typically I'll have people hold that for 5 to 10 seconds. Again, this is one where we're gonna do several sets, several repetitions in order to make it an exercise, and that helps with tongue strengthening. So that's a fun one. Effortful pitch glide I won't do because I don't want to sing right now and turn it to a microphone, but I'll explain it. So basically, you're going to use the vowel E, and you're going to go to your highest pitch, okay? And then you're going to hold it there for 5 to 10 seconds. Some good feedback on that one is if you find your Adam's apple, you should feel it moving up. Okay, so if anyone wants to try any, feel free, or if anyone wants to see it after, I'll do it with the mic off. And then expiratory muscle strength training, we're going to talk about that one in another slide. And then patient and family education, typically it is a combination of these approaches. Again, it is important to see an SLP, a speech language pathologist, because everybody is different, so everyone's going to have different recommendations. In some extreme situations, if the swallow is severely impaired, a feeding tube might be recommended. That's not very typical, but it might be a recommendation for some if these options don't work. Sometimes it's a temporary solution while we're rehabilitating the swallow. Okay, adaptive equipment options. So these are the ones that I typically like to recommend. So these all control the flow of the liquid. So if your recommendation is to take small sips, this is gonna help you take those small sips. So the ProVail cup comes in 2 different types, 5 cc's, which is equivalent to a teaspoon, or 10 cc's. So 5 cc's has a blue top, 10 cc's has a brown top. So this one, it's gonna control how much of that liquid comes out. You're gonna set it down before another sip of liquid comes out, basically. So this one can be purchased through Amazon or directly through the ProVail website. This one is ideal for cold or room temperature drinks and thin liquids. Now, okay, if you have a recommendation for thick liquids and small sips, the wedge cup is a great option. So the wedge cup is for thick liquids. It has 4 settings depending on how big of a sip you can tolerate. And this one can be used with hot or cold. Again, this is another one that can be purchased through Amazon or through their website directly. And for all my straw lovers, there's a safe straw, and this one controls how much liquid comes out through the straw. So the white one is for thin liquids, and then the blue is gonna be for a nectar thick liquids. So Amazon or directly through the Safe Straw website on that one. And then next, thickener options. So if your swallow study was completed and they recommended thickened liquids, here's some options. So Simply Thick is gonna be a gel-based thickener. Gel-based thickeners tend to stick or hold the right amount of thickness better over time, so they don't get thicker over time. And they can be used with hot or cold drinks. It comes in 2 different varieties. So you can get the pink, which is like a nectar or mildly thick, or the yellow, which is honey or moderately thick. Your speech language pathologist, will tell you which consistency you need. And it comes with individualized size packets or like a big pump bottle. So this one can be used hot or cold, purchased directly through their website or through Amazon as well. And this one is a little more costly, but again, it holds better over time, can be mixed with different types of liquids. Then we have Thicket. This is gonna be a starch-based or powder-based thickener. So this one does thicken a little bit over time, meaning if you leave it out, it's not gonna hold that recommended consistency quite as well. It is more cost-effective though, and you can find this one at some Walmarts, Amazon, or directly through their website. This one doesn't do as well with hot liquids either, but it does good with like cooler room temperature. And then if you don't want to worry about thickening things, you're just, not in the mood, or you're just kind of sick of it, I get it. Thick and Easy comes with pre-thickened liquids. So they have juices, teas, flavored waters, and it comes in big jugs or like an individualized size packets. This is another one that can be found on Amazon or directly through their website. So lots of options for a thickener if that is a recommendation. Okay, expiratory muscle strength training. So I love using this device for people with Parkinson's. So it is a handheld device and it has a pressure valve. So the goal is to break that pressure valve by blowing into it using as much muscle force as possible. So it targets your expiratory muscles and your submental muscles, these muscles right here, to break that pressure valve. So it has been shown for people with Parkinson's to improve cough strength, voice, improve swallowing, improve general endurance and physical capacity, respiratory capabilities. Typically, the recommendation is 5 sets, 5 reps, 5 days a week. It comes in 2 versions. That green is the light, so meaning it's easier to break the threshold. I typically start people off on that one because the blue starts at a very high threshold, so it's really hard to break that seal with the blue. And the other thing, if anyone here has Medicare, the green one is covered at 80% with Medicare. But you do have to have medical necessity and a doctor's order. So that can be completed with your doctor or speech-language pathologist. There's some paperwork involved. We get it signed by your doctor. Then it gets turned into the company, Aspire, and then they send the device directly to your home. So 80% for the light one if you have Medicare, and then supplemental should cover the remaining. And it's only like $55, so after the Medicare, it comes up to like $10 or $15, and you can use it for a long time, and it does have a warranty on it as well. So this has been wonderful in my practice, easy to use, so this has been good. Speech and voice treatment for dysphagia. So it has actually been shown that using a program like LSVT Loud or Speak Out can also help your swallow muscles. So our speech and voice muscles share a lot of the same anatomy as our swallowing muscles. And sometimes the problem is our voice muscles, our vocal folds maybe aren't quite strong enough. So these treatments can strengthen that and then therefore also strengthen your swallowing. So if you've completed these programs, there's a good chance you've also done some swallow rehabilitation and you didn't even know. So if you guys have any questions about either of those programs, feel free to ask me afterwards. I'm happy to talk about them. Drooling. So a common symptom of Parkinson's is drooling. So the medical term for that is sialorrhea, and it can range from mild to severe. So the amount of saliva you have has not actually increased. What's going on is people with Parkinson's aren't swallowing as often, and they're not swallowing as efficiently. So what's happening is you're just not managing your saliva as well. It's still the same amount, you're just not managing it as well because of that weakness that comes with Parkinson's. So what can you do? So there's some less invasive to more invasive options. Less invasive is just going to be to swallow more often and with purposeful and intentional meaning, basically. So like anything else with Parkinson's, we have to have intent. If that seems hard, you can start with using an interval timer. So swallow prompt is a timer, or just use your cell phone. Set it for anywhere between 15 to 90 seconds. Practice that for a couple of days or a week to kind of get used to how often you're needing to swallow, to recalibrate your brain basically on how often you're needing to do that. If you're out and about and you don't want to use a timer, so you can use an external cue. So let's say you're at dinner, you're with family. Before every time you take a turn speaking, swallow. So that is a wonderful external cue that, is not using a timer or anything like that whenever you're out and about. Some more invasive options, there are some medication options that are out there, so talk to your doctor about those that can reduce the amount of saliva so it's easier to manage. Botulinum toxin injections to the salivary glands is another option if the first 3 aren't working out so well, if the drooling is severe. The thing with the pharmacological and botulinum toxin is it can cause or worsen dysphagia, so make sure you talk to your doctor about any pre-existing signs or symptoms before getting those interventions, because it can worsen them or result in dysphagia if it's not already there. Last big thing we'll talk about is swallowing pills. So swallowing pills, pill dysphagia, also very, very common with Parkinson's disease. So this can include feeling like the pills are sticking in your throat or in your chest. It can be fear of swallowing pills, avoiding swallowing pills, having to crush your pills. So this is very common, and some things that you can do is ask your doctor or pharmacist about orally disintegrating options, smaller tablets or liquid forms. There are other options just because pill dysphagia really is so common. There are other options for how to take your medication. Sometimes taking it with the food can be helpful, so like a yogurt or a pudding. However, sometimes using those can be contraindicated. If your medication can't be taken with food, don't do that because it won't absorb the way it needs to. Also, sometimes some medications are contraindicated with like a dairy or a protein-rich food or a citrus. So just make sure those aren't contraindicated before using them to get the pills down. There's also pill swallowing gels, mouth sprays, and pill coatings that are available to help them kind of glide down better. Also, request a swallow test. So during that modified barium swallow study, there are barium pills that can be administered so we can see what's going on and what's causing that pill to get stuck. Some things you should never, ever, ever do is chew your medication, crush your medication, split your medication, do anything with your medication without talking to your doctor, because then your medication's not gonna work the way it needs to. So if you have this problem, it's okay. Talk to your doctor because there are options that are gonna be safe and still make your medication work the way it needs to work. Dysphagia resources, for time's sake, I won't go into these. I do have a handout right up here, so for anyone that's interested, all of these resources are listed on this handout on stage. And now we're just gonna go into some key takeaways before I pass it on to Stephanie. Difficulty swallowing is a very common symptom of Parkinson's disease. Again, 80% of people have this problem. Only 3 to 4% of people get referred, okay? So if you have any of the symptoms we talked about, coughing, choking, wet voice, difficulty getting that food down, talk to your doctor and ask to see a speech-language pathologist because the swallow test does need to be completed, and from there we can provide treatment. Swallowing disorders are treatable. There are things that we can do to maintain, improve your swallow function, and maintain and improve your quality of life. A strong cough helps protect your airway, so if you ever feel the urge to cough, cough. That is your body trying to protect itself. Drooling can be helped with medications or botulinum toxin injections if some of those external cues or just consciously telling yourself to swallow more often don't work, but again, use them with caution if dysphagia is present. And then early intervention and frequent follow-ups are important. Parkinson's is very manageable the earlier we kind of start that treatment process. So yes, that is all I have, and now I'm gonna pass it on to Stephanie.
All right, so again, my name is Stephanie Gill. I was born and raised in Naples, Florida. I then went to the University of Florida, go Gators. I then went to Emory University, and after that, ended up at One Rehab, where I've been for the last 3 years. I enjoy traveling with my husband and my adorable dog, Archie. So to start off, I wanna go over the brain and movement. So normally, the basal ganglia is responsible for a lot of functions, such as executive functioning, motor learning, behavior, balance, walking, and so that's sort of its normal function, but a lot of the changes that we see with Parkinson's are a result of the changes that happen in the brain, and so normally, our balance is an automatic reflex. But what happens is with Parkinson's, because that basal ganglia is impaired, the brain then reassigns this task to the thinking part of the brain, the frontal cortex, in order to compensate. And as a result, your movements require a lot more attention and a cognitive control instead of being as automatic as they normally would be. And so when it's less automatic, it requires more attention. And so we have this dual task interference, which is essentially when you're performing 2 simultaneous tasks at the same time, you can have deterioration of one or both of those tasks. And so we see dual task interference being a lot higher in people with Parkinson's because since you're having to put a lot more thought and attention to your movements, they're not happening as automatically. When you go and add another thing to that equation, you might have a disruption in one or both of those. So if you've ever been walking and talking, having a conversation with someone, you might notice that maybe your movements are slowing down, or maybe your talking has slowed down, or maybe you started to notice that your feet aren't taking as big of steps as they were before. So this is where a lot of that dual task interference is when you're trying to do those 2 things at once. And so as Anna had mentioned earlier, this is where it's really, really important to make sure that you are doing everything with intent and purpose. You really want to make sure that you are focusing on the task that you're doing so that all of your movements are coming out as you are intending them to do so. And so next, I want to talk a little bit about walking with Parkinson's. So here on the left, you'll see what we would call normal gait or your normal walking pattern. And then on the right, we have what we would consider a typical Parkinson's gait. And so that's where we see some of those shorter steps closer together. This might kind of resemble, that shuffled gait that you might experience. And so what happens is when that basal ganglia is impaired, there's difficulty with the initiation and execution of your movements. And so that's where we start to see also some of those slower steps and not taking as big of steps as you might be intending. And so one of the things that we see when these steps become smaller or when you're having some impairments with initiating and executing those movements is freezing of gait. And so this is when you're trying to move forward and your feet stop moving. They're not doing what you're trying to get them to do. So we call this freezing of gait, and it typically occurs when you're walking in a crowd, when you're going through a narrow hallway, maybe walking through elevator doors, when you're walking from maybe a wood surface to a carpeted surface, or if you're trying to turn in place. And freezing can also happen not just with your walking, but it can happen with a lot of movements and even your speech. So for example, if you're trying to stand up from a chair and take a step forwards, you might experience some of that freezing if you're in a stressful situation, as well as if you're multitasking. So again, this is where that dual tasking comes into play. If you're trying to do two things at once, if you're not focusing on that walking, you might end up having one of those episodes of freezing because you're trying to pay attention to something else at the same time. So, if you're feeling stuck, what can you do to get out of this? So the Parkinson's Foundation actually has a really great strategy called the 4S strategy. And so one of the first things you're going to do is just stop. Stop your movements, pause what you're doing, and take in a nice deep breath. And then just go ahead and let that breath out. And that's where the second S comes from, is just taking a sigh. And then from there, once you've kind of stopped and paused everything, you're going to try to shift your weight, either from side to side or forwards and backwards. And then once you feel comfortable enough, you've been shifting that weight, you're then going to try to initiate that nice big step forwards. These other strategies here can be used in conjunction with the 4S strategy or just on their own, but one that I really like to teach patients is just marching in place. This kind of gets both the taking the big steps and shifting your weight side to side. This is also another great one if you're using an assisted device like a walker or a cane. You can kind of cue yourself, and we're going to go over some of these cues on the next slide, but lifting those feet up and getting your knees towards the handles of your walker can be a good cue to pick those feet up high enough and to also get that sufficient weight shift. You can also try using a mark on the ground. If you're feeling stuck and you see something in front of you, even if it's a speck of dust, try to get your foot to take that big step towards that target to continue your walking. Also, if you're trying to turn in place, try instead to turn in a circle versus pivoting on your foot. So I like to tell people turn in 90-degree circles instead when you're turning, making sure to pick up your feet. And then the other really important one is just family and caregiver education. So if you're with someone and you're experiencing an episode of freezing, make sure that they don't rush you, okay? You want to try to instead have them kind of go through this 4S strategy with you. Help them educate you on just, pausing your movements, taking a deep breath. If you're having some trouble, they can actually help you get that weight shift, and they can even be a target for you. They can kind of just place their foot a little bit in front of yours and give you a target to step to kind of break that episode of freezing. And so with that, I wanted to give you guys some strategies on how to improve walking. So we kind of talked about what's going on with movements, with initiating and executing movements. We've talked about what can kind of happen when you're walking and talking, doing too many things at once. Now let's talk about how can we improve overall walking. So you'll notice some of these cues here are similar to how you can get out of an episode of freezing, and that is because external cues are so important. Your basal ganglia acts as your internal cue generator. It kind of gives that information to your brain about what your body is doing. But if that's impaired, You have to use more external cues to make sure that the movements you're trying to do are coming out as intended. And so one of my favorite things to teach people, especially if you're not using an assisted device right now, is when you're walking, try to get your foot to pass your other foot. If you're taking small steps and you're noticing that your foot isn't passing the other one, try to make sure to take those nice big steps on the next step that you're taking, as a way to ensure that at each step you're taking is a big one. I don't necessarily recommend staring at your feet the entire time that you're walking. Instead, just kind of check in with your movements as you go, or if you're noticing you're having a little bit of a hard time taking that next step, look down at your feet and make sure that each step you take, you're passing your foot. Another one you can do is a metronome. This is a great auditory cue in order to keep your tempo and your cadence. It's another great one to make sure that you're taking even steps, which can help with those episodes of freezing. I recommend starting at a slower speed of around 80 beats per minute and making sure that you have someone around you to make sure that you're being safe while you're doing this, and then you can try to ramp up that speed to kind of get that normal gait pattern that we're looking for. Another one you can do is stepping over an imaginary line or using a laser. So there's a lot of things on the market right now. You may have heard of like the U-Step walker that has a laser and a metronome. There's also a neck stride device that's more portable and can be put on any assistive device. It's basically a laser, and it gives you that external feedback that you need to say, yes, I reached my foot to that laser, I took a big step, or no, I didn't, so let me make sure I try to change that movement on my next step. And then one that you can implement with all of these is just taking large voluntary marching steps. So with everything that you do, we want to be, again, moving with intent and purpose, taking those large, big, effortful steps. And so one of the most important things that you can do to improve your walking, to improve your overall mobility, is exercise. So 2.5 hours of exercise per week has been shown to not only improve quality of life in people with Parkinson's, but also help delay some of the slowed movements you might experience, balance impairments, a lot of other things like improving your strength and your power, which is needed for those large amplitude movements that we're looking for, improving your fitness and reducing your fatigue, which might sound a little bit backwards because I'm sure when you work out, you're feeling pretty fatigued in that moment, but over time, these exercising regularly can actually help with those fatigue levels. Improving postural control and relaxation of tight muscles. This is going to help with your overall balance, which is really, really important in preventing those falls. And then improving your speed of walking and mobility. And because Parkinson's is seen as a movement disorder, a lot of the time some of the non-motor symptoms don't get talked about as much, but they're still very much important. And luckily, exercise has also been shown to help with a lot of those, such as depression, anxiety, sleep disturbances like REM sleep disorder, memory, executive function, and fatigue. And aerobic exercise has actually been shown to be the most beneficial for improving memory, but all forms of exercise have actually been shown to improve cognitive function in people with Parkinson's. And one of the most important things is that research has actually shown that exercise can help you gain back some of that automatic balance reflex. They believe that because exercise can help with neuroplasticity, so your brain's ability to form new connections, restore old ones, and even maintain some of those lost ones as well. And so this is really, really important in terms of getting that automatic function again so that you're not having to put as much attention and control to your movements. So, speaking of exercise, I wanted to go over some exercises that I love to do in the clinic that are really great for improving your overall function and walking and balance. And so the first one I have for you guys is standing up and sitting down, which you probably do multiple times throughout the day, but you might find that sometimes you're having to do it multiple times just to get up from the chair. So I wanted to go over some tips with you guys. So if everyone wants to try this one out, I'm gonna have everyone scooting to the edge of their chair. And we're gonna do a nice big lean forwards using the external cue of leaning your nose over your toes to get that weight in your legs. And then you're gonna take a nice big explosive movement up to stand up. Good. And when you go to sit down, you wanna make sure that you're reaching your hips back towards that chair, bending your hips and your knees at the same time. Good. And so for this one, using that cue, nose over toes, is going to make sure that you're getting that big lean forwards that you need in order to stand up. Awesome. Really good. Okay. So next, I have marching. This is a really, really great one if you're having an episode of freezing, if you're just trying to improve your movements to take those larger amplitude steps. So whether you're doing this one standing up or if you're doing this one seated, make sure that if you're doing it seated, you're not relying on the back of that chair. You're holding that nice, good posture, really using that core to do this one. And this, again, you can use that walker or even like a kitchen counter to give you that cue to get your knees up all the way up to that surface so that you know with every march you're doing, you're taking a nice big step. There we go. Good job. All right, and this is just a picture showing you in a seated position, just making sure you've got that nice, good posture. And this is a video of one of my patients doing some marching in the clinic. So this one here is a really great one for also working on your weight shift, but working on your balance as well. And so for this one, you can do this seated or standing. If you're gonna do it standing, you wanna make sure that you're standing nice and tall. And again, I would recommend probably holding on when you're starting some of these exercises, and then once you feel comfortable, you can do it without holding on to something. But you're gonna try to shift all the way over onto one foot, trying to point that toe if you can, and then you're gonna reach up like you're reaching for something in a cabinet, and then coming back, and then we're gonna reach to the other side, trying to point that toe, and then come back. Awesome. And so this is a demonstration of the standing version of it. Again, subtle, go Gators. And then the seated version of this one as well. And so this next one is a forwards weight shift. This is also great for just learning how to shift your weight, but it's also great because it kind of mimics that normal gait pattern that you see. So you want to start off with one foot in front of the other. You're going to shift your weight onto that front foot, trying to lift the heel of the back one, and then you're going to shift back onto that back foot, trying to lift your toe of the other one and just kind of rock forwards and back. I've got a video here as well. And if you want to progress this one, you can work towards getting some arm movement in there, which is really going to help you mimic that normal gait pattern. And the next one I have is kind of a progression to that forwards weight shift. I really like this one because it emphasizes those larger amplitude movements that we're looking for. So for this one, what you're gonna do is you're gonna be standing up nice and tall. You're gonna take a big step forward, shifting your weight onto that front leg and taking a nice big step back to assume that starting position. For this one, again, it could be really great to use a cue on the floor to step to and lunge to that target to make sure that you're taking that nice big step with each one that you do. And so I just wanted to quickly go over some other important factors. Shoe wear is really, really important. Make sure that you're not using slippers or sandals. These can easily get caught on rugs and carpet, especially if you're not picking up those feet as much. And we want to try to reduce the risk of falls as much as possible. Keeping your house well lit. As we age, we rely more on our visual system for our balance, and so if it's nighttime and it's dark, now we can't rely on that vision for our balance, and it can increase risk for falls. So make sure that, if you have to use the restroom at night, try to keep that path illuminated so that you are decreasing your risk for falls. Environmental setup. Try to make sure that your environment is free of clutter. If you need it, put some grab bars in there, some mats in the shower to, again, decrease your risk of falls. And then multitasking. Really try to make sure that you are limiting what you're doing at the same time. Even if you're going and you're getting your food and you're bringing it from the kitchen to the dining room table, you're probably way more paying attention to not dropping your food on the floor than you're walking, and that might, lead to an episode of freezing. You might not be picking up your feet as much, and we just want to reduce any risk of falls with that. And then assisted devices. So if you find yourself using walls, using furniture to keep yourself steady, it might be that it's time to look into an assisted device like a walker or a cane, but just make sure you talk to either your doctor or physical therapist about this, because they can tell you what's right for you. They can also help you with fitting of it, and at the same time, they can help you learn how to use this, because with using an assisted device, it's basically like learning a new skill. And so instead of paying attention to that walking, you're paying attention on how to use that cane correctly. And that's where we get some of that dual tasking interference there. And so just make sure that you're doing this with someone who can make sure that you're being as safe as possible. And lastly, some takeaways that I have for you guys, as both Anna and I have mentioned throughout this presentation, is making sure that everything you do is with purpose and intention. We had a patient a few weeks give us the great analogy of whenever you're moving, try to think about walking and talking like a billionaire, or walking and talking like a soldier. Whatever that cue is that's gonna work for you, that's gonna make you stand up tall, project your voice, and make sure that you're moving with intent and purpose. Think about that with every movement that you do. Limit your dual tasking. I won't go into that one anymore, as I've already harped on that enough. Use external cues for your mobility. This is a great way to give that feedback to your body if your movements are coming out as you're intending. And then again, make sure you're exercising for at least 2.5 hours a week to really help with your overall quality of life and mobility. And lastly, make sure that you reach out to a speech or physical therapist for individualized recommendations. No one person with Parkinson's is the same. Everyone has things that they're working towards. Everyone has their own goals, and we're here to help you achieve those. Your goals are our goals, and we just want to help you move and function as best as possible. Thank you guys so much. I don't know if we have time for questions, but this is our contact information. If you guys have any questions whatsoever, we have our cards. I also printed out some of those exercises that I went over, and Anna had those dysphagia resources for you as well.
Thank you both so much. We have a couple of gifts for each of you. And again, they can be found at One Rehab, which is not too far from here.
We have a Richardson and Dallas location. So.
Two locations. Excellent. All right, we are at the end of our program. So Keisha has got the raffle prize. So she's going to draw a name, see who our winner is today. Okay, and the winner is Karen Graham. Is Karen here? Yay, Karen is here. Wonderful. Excellent. Thank you all so much for being here. As you know, we can be reached at daps.org. And until next time, we hope to see you at one of our monthly educational series in Duncan, Denton, Dallas, or McKinney in November. Stay safe.